Welcome to Knowledge on the Go, where we explore the leading practices that have emerged in Vizient's Performance Improvement Program. I'm Marilyn Sherrill, Senior Performance Improvement Director at Vizient and your program host. In this podcast, we'll discuss the emerging practices identified in Vizient's High Reliability Culture of Safety Collaborative and explore the challenges as well as the nuts and bolts of how to become a highly reliable organization. Vizient's definition of a high reliability organization is an organization that has experienced significant success in avoiding harm within an environment of high complexity and risk. These create a collective state of mindfulness that produces an enhanced ability to discover and correct errors before they escalate into a crisis. Failing to establish this mindfulness infrastructure impairs the ability to perform reliably when unexpected events occur. Joining me today are Caryn Douma, Corporate Director of Patient Safety, Penn Medicine, and Dr. Michael Leonard, Senior Principal with Vizient. Caryn and Dr. Leonard, welcome. Dr. Leonard, do you mind if I call you Michael?
I would appreciate that.
Vizient recently completed a collaborative project focused on high reliability culture of safety, followed by a webcast featuring Penn Medicine's high reliability journey and the work that they did during the collaborative. So many times we hear from our providers that they are seeking the nuts and bolts of how to implement the essential elements to advance their journey to becoming a high reliable organization. Now, that seems like a big ask, but given your experience, Caryn, and your expertise, Michael, what would you advise? Michael, I'm going to start with you.
The journey at the University of Pennsylvania has been an impressive one and is a great example of how to do this methodically in a way that creates sustainable value. If you think about embarking on a process of high reliability, there are some essential elements. And if we use the Joint Commission, Chess, and Loeb's model, effective leadership, culture, safety, continuous learning, and improvement, that's a pretty good place to start. Effective leaders are present. They talk to the people doing the work at the bedside. That's where the wisdom lies. And they gather insights as to how to support that work, how to deal with obstacles, defects, barriers. And then they have a very consistent process of managing that information and providing feedback. I would put feedback in capital letters. Rule number one, you need to listen to what they say. You need to work on it. You need to come back and talk to them. And we have abundant cultural data from our SCORE survey that we can see 30 to 40 point differences between teams and team members that feel like they have a voice, they have influence, they're valued by the organization, and the organization's acting on that. Culture is the glue that puts together all this profound technical expertise of our docs and nurses and it's the attitudes and behaviors. If people feel valued, they have psychological safety, they feel comfortable to speak up. This is where team mechanisms like huddles and debriefs become critical. The leaders are available, the leaders are approachable, and we know from a lot of work in safety in high-risk areas that once you've spoken and you've been affirmed and valued and treated with respect, you're far more likely to speak up. And we also know that you want people to play offense so they can basically understand what they expect to happen. So if something's not going the right direction, they'll be very quick to raise their hand. The goal is everybody knows the plan of care for patients, and the team can be proactive as opposed to what our team members deal with all the time now. They just try hard, and it's a reactive environment full of surprises, interruptions, distractions, which is exhausting and also dangerous. And the third part of this is you have to have visible, sustainable processes of care so you know you're delivering the right things. And you know when you're not, so you can intervene early and course correct. Those are the essential elements. This is a journey over time. The organization needs to be deeply committed to it.
That's a great segue into a question for you, Caryn. Your organization has been on this journey for many years. And so given your experience, what would you recommend?
I completely agree with everything that Michael just said. I think that he put it all in a nutshell for us. At Penn, we started way back in 2005, 2006, before I came here. I've been at Penn for 5 years, around the time that everyone was looking into high reliability and how do we really improve our outcomes. There were assessments, surveys, all showing the exact same thing without any action. One of the things that was very critical to our journey is we recognized that we needed to have senior leader engagement from the get-go. Then reach out to an external consultant. We knew that we did not have the resources internally We brought in our consultant, spent the first several months hearing from senior leaders and understanding where we were we committed, and was this the right time, and were we ready to go? We did our first executive academy with over 100 executives from around the whole health system, and we were able to do 20 hours worth with that team member over a number of weeks. And we did didactic sessions, we had coaching for implementation sessions, a lot of conversation. And during that time, we recognized we needed a framework, things that resonated with everyone that were simple, easy to remember, that we could just take and say, here's a visual that we can spread far and wide that everyone can look to as the true north. So we adopted the safe and reliable framework and made it our own. That was how we framed our didactic sessions. We had separate coaching sessions where groups could get together, talk about the concepts, talk about what they learned. And it was very inspiring. But again, small part of the organization considering how many we have. So the next phase that we kicked off was to create a series of modules, a refresher, and then an intro for the staff members who had not been exposed other than through their leaders. And that was the expectation. It was critically important that the leaders are present and in the moment with staff. The idea was that the concepts that we were discussing with our senior leaders would trickle down to our frontline staff. At this point, we are about 3 years in, but I feel like we took the time to gain the leader engagement and to put the foundation in place so that now we're ready for our next phase.
Now let's turn to a recent survey we conducted where we asked participants if there were specific components of the high reliability topic that they would like to address. Let's start with this one, Caryn. What are the best ways to close the loop with frontline staff at a very large, comprehensive academic medical center?
That is a huge challenge. Number one, when you have multiple entities in the same organization, it's hard to get everybody going in the same direction, even from a high level. One size doesn't fit all with this. Probably the most important piece of this is for leaders to be present, to listen. And that's often the thing that we forget the most. Engage your staff and provide opportunities for them to participate. And both at Penn and in my past experiences with high reliability and other organizations, the piece to me that really turned the corner and made you feel like you were getting over that first hill and really getting somewhere was when you were connecting with the frontline staff. Not just grounding and chatting, but really connecting, listening to suggestions about quality, about improvement. We can't do everything, so you do have to prioritize. What we fail to do in terms of closing the loop is we shy away from going back when we know that we can't deliver, and we can't do everything. We don't have limitless resources. But the most important part is when you're coming back to your staff saying, you know what, we took this to senior leadership. We had this conversation. These are the couple of things that we can do, but these are the things we're going to have to put in a parking lot that we really can't do right now. Staff really appreciate that. They don't necessarily think you're going to do everything that they ask, but what they do expect is that you're going to respond and be transparent and help them understand the reasons why everything is not necessarily possible.
Michael, how do we make those round episodes meaningful?
If you want leadership walkarounds to be effective, it's probably the most valuable activity you can take on at any given time. You need to be systematic about it. You need to train people, educate them, make sure they're going out when they say they're going to go out. Because if you say you're going to go, go. And when people tell you something, you have a fundamental obligation to act on it, learn, and give them information back. They're going to tell you a lot of things. Some of those are going to be simple. Some are going to be complicated. Some are going to be very complicated. But it's really important to focus on the things you can fix. One is you need to have the right conversation, and it's appreciative inquiry. Our colleague and friend Brian Sexton at Duke, big advocate of positive rounding. When I go into organizations and talk to people, the first question I always ask is, take a few minutes and tell me some aspect of your work you're really proud of, because they do great work and they all have a story. And once you've had that conversation, they know you care about them, and they're much more amenable to the second question, which is what could be better here? And just listening, learning is a very, very powerful tool. Let's think about where we are with our workforce in American healthcare today. They've been ravaged by COVID. We've lost a lot of very, very experienced nurses through the institutional knowledge. And so we have a lot of new people that are novices. And that pathway to wellness is that people walk in, they feel part of a team, they feel like they're making a difference, they are appreciated, and they have a sphere of influence. And that's why knowing the plan, effective teams, effective huddles, you can come and play offense. If you're in an environment where you keep raising your hand and nothing ever happens or nobody listens, then you can come to a very logical conclusion that nobody cares and you're by yourself. And that just perpetuates burnout. What we saw through COVID, because I've been measuring culture for a couple of decades, is the leaders that were intentional about leader rounding, they stabilized or actually improved their cultures. The ones where people didn't show up, where they didn't know what to say, those cultures went very much backwards.
So, Caryn, this organization says we're struggling with patient care tasks reliably being completed. For example, turning patients every 2 hours to prevent pressure ulcers or completing all the dressing care, bathing for central venous catheters. This organization says, I would like to learn how other organizations are ensuring reliability with nursing and physician practice.
That is a tough question, and everyone struggles with it. And I also think it's cyclical. One thing that we want to start with is post-COVID, we had a lot of experienced nurses and physicians leave. We had a lot of that historical knowledge leave and a lot of new to practice providers that learned in a virtual environment. We also are in a difficult financial environment in healthcare, which means that there has to be corners cut in amount of time for orientation, onboarding, and that mentoring that is so important to be able to know exactly how to do things. There is still an art to it. The other part that we focused on when we started our formal high reliability journey was personal accountability. Straight across the board, treat everybody with respect and treat everybody the same. But when things do go wrong, start with empathy, start with being kind, but it doesn't mean that everyone can do what they want all of the time. And I think that's a basic foundation to the clinical struggles that we all feel around making sure the checklists are followed, patients are turned, and if you don't follow guidelines, you're not going to get the desired outcome. We still struggle with that in healthcare, but without that personal accountability piece, along with our teamwork, it's very difficult to achieve the outcomes that we want.
I would completely agree with that. There's one set of rules and personal accountability, and that has to be core to the culture. The other piece is to go have the conversation. So if we're having trouble with the elements of a sepsis bundle or having trouble turning patients with a frequency, go talk to people because they all get out of bed wanting to do the right thing. We have incredibly dedicated, wonderful people and saying, what are the things that are getting in the way? And it's usually the little things that get in the way that lead to the big things not coming out the way we want. That's all part of that rounding learning environment to say, how do we support you in delivering optimal care? And if you go talk to people who are taking care of patients, it's pretty obvious that even though we're extremely well-intentioned, sometimes we make it very hard for them to do that. If you think about it, we've been adding additional work, policies, complexity, but we don't have the bandwidth or space to say, what's the non-value work that's getting in the way that we can get rid of that allows you to focus on what's important?
Caryn, there's an organization in the survey that wanted specific information on changing culture, motivating staff that are slow and resistant to change, as well as reframing our processes so that we cultivate a just culture that focuses on setting our staff up for success rather than punishing when outcomes are not as intended.
We started with creating a fair and just culture decision guide and intended to move right through and implement a more formal program around fair and just culture. We had to put the brakes on that. We had to do a little bit of a pause because we felt like we needed more foundational elements in our environments, and we were getting a little bit of pushback, a little resistance. We already have 2 entities within our organization that have been working through this with different models for the past maybe 5 to 7 years. We all came together to come with one for Penn Medicine. It took us a while to get everyone to come to consensus. We're going to be launching a module in the next week or so, and then we're going to be co-creating our formal program. It's a heavy, heavy lift, and it starts with feeling comfortable speaking up as that foundation. Really feeling like you can say what you think in a respectful manner. If people don't feel comfortable speaking up and saying, sorry, I think that you contaminated your glove, here's another one. Those are the things that happen every day. The way that we're trying to make this move forward is that mid-level leader setting the standards and the behaviors in their area and rounding and being present with their staff. That's the piece that's the missing link to connect the dots and hold people accountable, but in a kind, gentle, empathetic way. When things don't go as expected, when things go wrong, how do we respond? Not react, respond. We've been working very heavily on messaging that. So when you're in any environment, it can be finance, it can be housekeeping, it doesn't matter. Something doesn't go as intended. The first thing that we are asking people to do is say, is everything okay? What can I do for you right now in the moment? And once we get through that, then we start working toward, tell me what happened and let's see what we need to do next. Are the patient and family doing okay? If it's that, or are your colleagues doing okay? So we are setting the stage that we're not going to jump to conclusions. We're not going to jump to negativity, and we're going to start to understand and figure out how we can learn from things. Everything is not going to be smooth, and there's always going to be things that need to be improved. I think how we set that foundation is going to be the most important piece. This is a journey. There's backwards, there's forwards, there's sideways. It's not something that you just decide that you've got your outline and your timeline and this is going to make it happen. This has been quite an experience for us so far in moving to this point.
I'd just like to reinforce what Caryn was saying. Ultimately, Just Culture is about building trust, having simple rules where people know they'll be treated fairly, and ultimately they feel safe to actually tell you what happened. And that's where you capture the narrative or the context in which these adverse events unfold. That's a rich, rich source of learning. Having this cultural base that you can learn from the things that go on in the organization, and having spent a lot of time in risk management over the years, what's extremely painful is when you have an adverse event or a medication error and you're sitting in a room talking about it, and then people start raising their hand and saying, oh, that happened to me. Because there's a real tendency in medicine that people are trained to never make mistakes, and their whole sense of self-worth is very tied to that. As a physician, people would make mistakes and they're like, well, it was a weak moment. I'll never do that again. And they don't talk about it, so we can't learn and prevent it from happening again. This is essential.
Well, there's a couple interesting questions, can sum up things a bit. The first is, how does an organization sustain their high reliability efforts amidst business distractions? And then the second one is, how does an organization create a culture of psychological safety, overcoming institutional barriers?
The way you deal with the business pressures, which are profound and they're not going away, is fundamentally you have to see high reliability as core to the work you do. And you have to have consistent processes. There is abundant waste and non-value work in American healthcare. And when you can learn and listen and start to take that out of the equation, that's where you get a competitive financial advantage in this. The whole model of fewer people trying harder is not the road to success. Let me just answer your question on psychological safety. Everybody knows what this is. They've had their personal version of working with people where you feel very comfortable saying, I don't know what's going on here. I made a mistake. Could you help me? Because you know they're going to be nice to you. And we've all worked with people where you're like, oh, this is not going to be a lot of fun. Think about the first time a new nurse has to call a physician at 2 a.m. That's a profound event. And that can either go badly and be a career-altering event, or it can be, this is cool, we're on the same team, we're trying to do the right thing for the patient. The two primary factors determining psychological safety, or whether somebody will speak up, come from Audrey Linden's doctoral work at UCSF. One is predictability. If I know the plan, I know what's supposed to be occurring, and it's not, then I'll be very quick to raise my hand. If I don't know what's supposed to happen, then I'm going to say, am I going to look stupid? Do they know something I don't? Am I going to get yelled at? Predictability is key. That's why briefings, huddles are so critical. And then the other thing is, what was my experience when I did raise my hand? If somebody was kind to me and respectful, I'll do it all day long. If they rolled their eyes, shrugged their shoulders, or yelled at me, game over. These cultural elements, the behaviors and attitudes of how we talk to each other, are essential for habitual excellence.
What final thoughts or advice do you have for our listeners today as they embark upon or continue their high reliability journeys? Caryn, we'll have you respond, and then Michael.
The most important thing is recognizing that it's a journey. There's many twists and turns, successes and failures, and you have to be persistent and not get discouraged. There's just going to be these times when you feel like it just isn't working, or you happen to be with a group of people that say, this doesn't make any sense. Why are we putting our energy into this? We have all these other things we have to do. And I would just say, stay the course. That's probably one of the most important things. Learn from each other, learn from what goes well, and learn from what doesn't. Hold everyone to the same standard. And you need to start with leadership at the senior level and dedicate resources to this work. And not just people resources, but also all of the accompanying things that go with your IT, your IS support, your housekeeping, everything that circles the patient and family. The only way you're really going to attain this or get close is if everyone's working together and everyone feels supported. Part of it is the constant learning and depending on one another and really being able to see and understand and share and learn.
That's an absolutely wonderful answer. A deep commitment to optimal care for the human beings that entrust us with their well-being and their lives. That's a sacred trust at a time that we're fragile and our workforce is fragile, that it's essential that we be kind to the people that we serve as leaders. And if we don't take care of our people, we're not going to be able to take care of anybody else. That deep commitment to the mission and that everybody walks in every day, regardless what they do. That's pretty basic. Having been in hundreds of hospitals over the years, that I would say to people, if you only allowed me to talk to 3 different groups of people in your hospital and figure out what's going on, they'd be the housekeepers, the unit secretaries, and respiratory therapy. If they tell you it's good, it's good. And those are the people nobody needs to be nice to. They'll tell you all kinds of stuff.
I can't say enough to Caryn Douma and Dr. Michael Leonard for sharing their time and expertise today. And to everyone listening, thank you so much. Please join us for more knowledge on the go. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com. From Vizient's PI program team, I'm Marilyn Sherrill.